Blog Talk Radio.
Welcome to today's episode of Inpatient Myeloma Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. Now, if you'd like to receive a weekly email about past and upcoming interviews, you can subscribe to our Inpatient Minute newsletter on the homepage or follow us there on Facebook or Twitter. And please share these interviews with your myeloma friends. For today's show, we are very fortunate to have with us one of the foremost world leaders in multiple myeloma, Dr. Antonio Palumbo. So welcome, Dr. Palumbo.
Well, thank you very much for the invitation.
Well, thank you so much for joining us. Let me introduce you before we get started. Dr. Antonio Palumbo received his medical degree from the University of Torino, Italy, where he served his residency in internal medicine and held a fellowship in hematology oncology. Before his current position as chief of the myeloma unit of the Department of Oncology, section of hematology at the University of Torino, Dr. Palumbo was a research associate at the Wistar Institute at the University of Pennsylvania. In addition to membership in numerous professional organizations, including the Italian Society of Hematology, Italian Society of Experimental Hematology, European Society of Hematology, American Society of Hematology, and the American Society of Clinical Oncology, Dr. Palumbo is on the board of directors of the International Myeloma Society. He's authored more than 150 publications in peer-reviewed journals, as well as numerous abstracts and several textbook chapters. He specializes in malignant hematology and medical oncology and has clinical and research interests in plasma cell dyscrasia. Just recently, Dr. Palumbo was awarded the Robert A. Kyle Lifetime Award for 2014 from the International Myeloma Foundation for many, many years of service and discovery for myeloma patients. So, Dr. Palumbo, thank you again for joining us.
Thank you very much for your invitation.
Well, Dr. Palumbo, one of the big reasons that we would love to talk to you, we have many reasons to talk to you as one of the world leaders in myeloma, but we are very fascinated about your paper, your ASCO paper in this year about continuous maintenance therapy. So before we start with that, can you please give us a brief introduction about the Italian Myeloma Network and a little background about that network?
Yes, basically almost, I would say even 15, 20 years ago, we started with the Italian cooperative groups called GMEMA, and we pulled together several hematologic institutions throughout the country, and this allowed us to start and with time have more and more clinical trials asking several questions. And just recently, the Italian group joined with some other European country to build up the European myeloma network, so that hopefully we'll try to even improve our current trial capability in order to make the study faster and probably better done.
Well, I very much appreciate the collaboration that happens in Europe. It seems to be a very collaborative group in the way that you're working together. Well, on the continuous maintenance therapy, let's talk about that for a little bit. I know you had, before this ASCO paper, you had papers in 2012 and in November of 2013 with lenalidomide talking about some of the rationale behind that. Can you kind of give us some background about the history of the rationale behind the idea of continuous maintenance therapy?
Well, basically, this idea started many years ago when we had a randomized studies comparing a treatment that was given continuously until progression versus a treatment that was given only for a few months. And the curves were very impressive, because basically the major differentiation in terms of outcome basically was shown when treatment was stopped. So while patients were on treatment, the curves were very well balanced, and they were starting to diverge dramatically when in one group we stopped treatment after a few months, and the other groups the treatment was given continuously. So we started to think about the need of continuous treatment basically from this randomized study. And basically the two important concepts were that if in myeloma you do have residual disease after induction, you might need a continuous therapy to keep this residual disease under control. If you stop the treatment, that disease will come up quite importantly and quite soon. So this was basically the concept that keep us evaluating this approach.
Okay, and do you want to share what you learned from what was in the ASCO paper? Because the specifics, it looked to me that the progression-free survival with lenalidomide maintenance was 42.7 months compared to 17.5, which is a huge difference.
Well, the ASCO paper was addressing this concept together with the idea of a resistant relapse. Try to explain the issue. In oncology today, we are not in myeloma specifically, but generally speaking, we do consider that treatment A is better than treatment B when the advance is a few months. With the continuous treatment, the difference in terms of remission duration has been constantly, in basically all studies, around 1 year. So the first major concept is that the continuous treatment is prolonging remission duration at the median, as a median value of 1 year. After that, the question becomes, well, okay, but if you prolong very much the remission duration, and this among aspects is a consensus that no one is discussing. But the next question was, well, if you prolong so much the remission, then the relapse may be quite aggressive, and you might lose in the subsequent remission what you gain in the first remission. So in this study that we presented at ASCO, we basically not only evaluate the length of first remission, but we also evaluate the length of subsequent second remission. So we put together the first and the second remission in the attempt to evaluate if the relapse after continuous treatment was shortening very much the subsequent second remission. And once again, in a randomized study, the results show that when you pull together the first and second remission, the advantage is still around 1 year when you compare first and second remission receiving continuous treatment versus first and second remission receiving just a short-term treatment. So the conclusion is that the delivery of a continuous treatment is not significantly shortening the second remission due to a more aggressive relapse.
And
I hope it's clear, because it was clear. Okay, because the concept is not always that simple to explain.
So you were basically trying to see if the first and second, if it extended both first and second remission times.
Yeah.
And that it had a year advantage. And then can you repeat what you said about the aggressiveness? Because I had some follow-up questions about just the aggressiveness. When it comes back the second time.
Mm-hmm. No, more resistant, more aggressive and resistant, because the one of the questions have been raised is that, okay, you prolong the first remission of 1 year, but then you shorten the second remission of 1 year. At the end, there is no advantage. This was the assumption, or if you want, the question, because if you give continuous treatment, the relapse will occur under treatment, under therapy, and at that point, that relapse could be much more resistant and aggressive. So the year you gain in the first remission may be lost during the second remission. This is actually not true. We could show that this year of remission advantage was kept also after the second remission.
So you are prolonging overall survival, and that was one of your second questions, right?
So that's become even a more complicated question, because the overall survival is, let's say, in 2/3 of the studies is prolonged. So you do see prolongation of first remission in 100% of the study. You see prolongation of first plus second remission in up to date 100% of the study, and you see overall survival prolongation, not in 100% of the study, but in, let's say, 2/3, 70% of the studies. How this is possible? There are several explanations for this. First of all, today myeloma is not one or two remissions, probably 4, 5, 6 different remissions. So the use of different drugs at subsequent relapse may alter the overall survival. And this is one of the reasons why in some studies we couldn't show consistently overall survival advantage. But the other one is also toxicity and the ability to receive an effective salvage regimen. And this may also change the overall survival outcome. That's the reason why we wanted to get specifically involved in first and second remission, to get close to the time period of the continuous treatment. Because if you go, in the old days, we only had 1, 2, maximum 3 remission duration. So it was very easy to translate the efficacy that was coming from the first remission to overall survival. Today, that fortunately we have 4, 5, 6 different remission duration. The overall survival might become, from this point of view, a more confusing endpoint, because so many other treatments, so many other toxicities, so many different comorbidities, complications may occur during those 4th, 5th, 6th remission duration, that this I'm not saying cancel, but create more confusion in the strict definition of remission duration and overall survival.
Well, if I hear what you're saying right, it just sounds like it might be a blessing and a curse at the same time. A blessing to patients that the overall survival is longer now with the newer drugs, but more complicated to determine what is actually creating that extended remission. And then running studies, it seems like it's a challenge because you have to have a much longer study to get the result that you want.
Not only that, but what my concept is that, when in a given disease you have 6 different remission durations, 6 different treatments, 6 different risks of toxicity during those 6 remission duration, it's very complicated to make a strict correlation between the efficacy of the treatment given during the first remission and the overall survival, because everything is getting mixed up by different risks that you might have, positive or negative, during the other 5 treatment lines and 5 remission duration. That's the reason why we try to pull together what we call PFS1 and PFS2, because to clearly evaluate the efficacy of a given treatment, and this was evaluated by remission duration, and eventually the risk of a negative effect that is coming just after that treatment, not after 6 of those treatments.
Okay, well that makes a lot of sense, that it is very complicated to determine and narrow it down. Go ahead.
Survival becomes more and more complicated to evaluate because more we have, the more lines of therapy, more everything can be confounded by subsequent treatments.
Right, so the efficacy and then the impact of the other treatments on your system and maybe on your myeloma.
Exactly.
Now, at the beginning of the show, you mentioned that one of the studies was looking at patients who had some residual disease. So can we talk for a minute about who continuous maintenance might be appropriate for? And maybe we start by talking about the remission status of patients. Is it appropriate for all patients who have some residual? Is it appropriate for patients who have a complete remission or a stringent complete remission? Could you inform us about that?
That's a very important issue, and I would say also something that needs some clarification. The outcome of the disease is the balance between 2, I would say, reality. One reality is how much the disease is sensitive to therapy, and more the disease is sensitive to therapy, more the residual tumor is reduced. So no questions that with a given treatment, if you reach a CR or even a stringent CR, this is much better than achieving a PR only, but a partial response only. But on the other hand, the other half of the moon is the biology of the disease. Because if you achieve a complete response, but the biology of the disease is very aggressive, the relapse might come very soon. On the other hand, if you are not very sensitive to treatment and you only reach a partial response, but the biology of disease is not very aggressive, and therefore the relapse will come after 5 years, this is, of course, a positive issue. So you have always to balance achievement of a good response of a CR with the biology of the disease. And this is, of course, to somehow not easy to do, and the real endpoint is the remission duration. I would say that the length of remission duration is much more important. The amount of response you might achieve after therapy. If you achieve a complete response, the duration of the response is much more important than the achievement of a CR or of a stringent CR. But generally speaking, I do agree that achieved CR is generally better than PR, but this must be balanced with the duration of response that might change from one subject to another, and this is mainly given by how much the disease is aggressive, and therefore how much quick is the relapse. On the other hand, the advantage of the continuous treatment is basically one, that with continuous treatment you might further increase the response achieved after induction, and therefore prolonging the duration of therapy might increase the response, improve the response rate. On the other hand, as we were discussing before, the continuous treatment might delay the relapse because it is certainly controlling the cells that might regrow.
Okay, so there are so many questions out of what you just said. So I know you're trying to balance between the biology of the disease and then the remission response. So some practical examples. If you had someone who had aggressive therapy and then hit a, let's say a stringent remission, has maybe one high-risk feature, maybe not a deletion 17, but something else, how do you determine if the length of the remission duration is the most important and they just came off therapy? Would you suggest that, or do you wait to see kind of the length of their remission response? That's kind of not continuous therapy. Can you give us some examples maybe for different types of patients, what you might do in those situations?
I think I don't know if I understood correctly, but I think we have to clear out two concepts. First of all, if we achieve a stringent complete response in a given patient, we still have residual disease. This is not complete response and eradication of the tumor. So it doesn't matter if we reach partial response, complete response, stringent complete response, even minimal residual disease negative situation, we always have residual disease. So we have to get rid of the concept that if I reach complete response, I'm cured because I get rid of the tumor. If I reach a partial response, I'm not, because I still have tumor. There is always residual tumor. So from this point of view, you see the advantage of continuous treatment is always present because you always have residual tumors. From a practical point of view, what we do in our clinic, according to the results of the phase 3 study, we do decide that a given therapy is the best available treatment for that given patient, and we give it to all patients. We are not changing treatment according to risk factors or achievement of response. We deliver what the phase 3 studies define as best available therapy, and on that evidence we deliver the same treatment to all patients.
Mm-hmm. And is that Revlimid right now, lenalidomide?
Currently, I would say as a continuous treatment, we actually have Revlimid as continuous treatment, but also proteasome inhibitor as continuous treatment today are do represent an advantage over fixed duration of therapy. Today, the evidence coming from the phase 3 studies are both from IMiDs and from proteasome inhibitor that the continuous treatment significantly prolongs remission duration of approximately 1 year. We do not have a comparison IMiDs versus proteasome inhibitors, and from this point of view, we cannot say that A is better than B or B is better than A. We can only say that the continuous treatment is better than fixed duration of therapy.
So at this time, you don't know if something like bortezomib would be better than lenalidomide as a choice. That's what you're saying?
Absolutely, yes. No, we cannot say it because we do not have any head-to-head comparison of those two approaches. We know that from phase 3 studies, both bortezomib and lenalidomide gave an advantage of approximately 1 year in 2 independent randomized studies.
Do you think any of the risk factors would come into play? Because I know that sometimes they say bortezomib might have an impact on 414 patients over other types of patients. Would you take that into consideration when choosing a continuous maintenance drug?
No, I don't. But I can tell you what, I should also say that depending on the reimbursement opportunity that are not always, they don't always give us the opportunity to give the best treatment. We do prefer proteasome inhibitor as induction, because this is a way to maximize as much as possible the response and to increase as much as possible the complete response, because today only combination including proteasome inhibitor could give, without autologous transplantation, a CR opportunity of approximately 30%. So we do prefer as induction proteasome inhibitors, followed by lenalidomide as maintenance, for 2 reasons. First, because we basically alternate the proteasome with the IMiDs, and second, to take advantage of the oral administration of IMiDs. That is certainly a plus when you are planning a treatment that could be longer than 2 years.
Oh, and I think that's a great choice because you want to have the patients stay out of the clinic as much as possible, if possible.
Absolutely, yes. And as I was saying, our approach is to take advantage of proteasome inhibitors that are certainly more effective than IMiDs in terms of increase the complete response rate, and on the other hand, to take advantage of the IMiDs for a continuous therapy and the oral administration of the IMiDs that allows us to keep patients out of the clinic for a longer period of time.
Okay, now when we talk about continuous maintenance therapy, can you share your opinion on dosage of that therapy? How do you maintain the best response with the fewest amount of side effect? What is your strategy to do that?
That's something. Thank you for the question, because I think that is probably one of the most important questions. This is a personal opinion. It's not given by any evidence, but my personal opinion is that maintenance and continuous therapy should be given provided they are not causing any toxicity. So my number one rule is continuous treatment should be delivered if all toxicities are minimal. And our policy is the moment we do see some toxicity, we eventually reduce or stop the therapy. We want to see those toxicity going back to a minimal toxicity, what we call a grade 1 toxicities. And at that point, we do restart at probably lower dose. So we basically, our golden rule is to keep patient on treatment with the dose that is not causing any toxicity. If we do see hematologic toxicities, we reduce the dose from 10 milligrams of lenalidomide to even 5, and eventually we stop. Because we do believe that the quality of life and the absence of toxicity are even more important than the efficacy in terms of prolonging as much as possible the remission duration. And here there is also, if you want, a more not very easy concept, but the concept is if you keep going on a continuous treatment, you end up and you start to see some toxicities, and you keep going, you will create a major toxicity that will end up in a clear discontinuation. So the two ideas are to minimize, to reduce the dose, to keep patient on treatment as long as possible. But on the other hand, to completely avoid major toxicity, because this has a major impact on quality of life from one side, but also on the risk of discontinuing therapy to excessive toxicities.
And a follow-up question, what specifically are you looking for when you look at toxicities? Are you looking for kidney function, or what specifically are you looking at?
Well, first of all, I would say hematologic toxicity, especially for also for both proteasome inhibitor and IMiDs, are probably the most relevant. Infection is the second most relevant, but once again, when we do the workout, we look at the hematologic condition, the creatinine, the renal function. Everything is not working properly is a good reason to reduce the dose. And this is especially important, you mentioned the renal function for the elderly, because the renal function is physiologically reduced in the elderly population, and therefore a reduced dose of especially lenalidomide is almost mandatory in this subject, because the renal function cannot be 100% conserved, and therefore especially in those patients, the dose reduction will be important not only for the kidney but also for the hematologic conditions.
And do you have any concerns about patients becoming refractory to a continuous maintenance drug?
Yeah, this is a concern. This is also happening, unfortunately. This is one of the major reasons why we ran the study pulling together the first remission with the subsequent remission, in order to evaluate if the resistance was creating a major damage for the subsequent remission. The data are showing that this is not in the practice so true, that some patients do acquire a clear resistance to treatment, but they are probably less than 20%. So the majority of patients are not acquiring a major resistance to therapy. And to some extent, when we balance the risk of resistance that is certainly occurring in 15-20% of patients versus the advantage you give keeping the tumor under control with continuous treatment. There is much more advantage in keeping the tumor under control than the disadvantage coming from the occurrence of resistant relapse.
And it seems that you're always trying to take that balance, the maximum effective therapy and the minimum downside for the patients. Yeah.
Absolutely. I think this is the key issue. Minimize the treatment if you want, minimize the toxicity to maximize the treatment. And I think this is probably rule number one.
So I have a question about newer therapies. With some newer therapies, because there are so many different types now, all these different inhibitors and vaccines, are there other therapies that could be used as continuous maintenance therapy, like let's say, for example, a vaccine? It might be too early for that. That doesn't have any side effects, but might help boost the immune system and keep it going. That, in your mind, could any of those be used as continuous maintenance therapy now or in the future?
We hope for the future. Today, there are no evidence that vaccine can be used as continuous therapy. We do need some clinical studies to show that there is a clear efficacy, because vaccine could mean so many things, so many approaches, and one slight difference in one approach over the other could make an enormous difference. But the main message today is we do not have any clinical evidence of efficacy of vaccine in myeloma. That doesn't mean that tomorrow this evidence will come. My concern is that the treatment should be delivered outside the clinical trial, because in a clinical trial it's a completely different story. But outside of a clinical trial, when we do have evidence of efficacy. Today, there are some clinical trials evaluating vaccines. So if someone would like to test the efficacy of a vaccine, should be included in a clinical study that will allow us to evaluate if this approach is effective or not, but shouldn't use outside a clinical study, because today we do not have any evidence, and we, on the other hand, need the evidence to show that vaccines are effective. They are a great hope for the future, but once again, we first need evidence and then we can use it.
Well, maybe that's just my hopeful dream world of treatment without any side effects. But it is very positive what you said, with 80% of patients not becoming refractory to the therapy that's being used today. So that's very encouraging.
Yeah.
So,
I was, okay, go ahead. No,
that's
go
okay.
ahead.
So in looking at this, I know studies are difficult or a challenge, because you have to do a study for a certain time period to find a result. And I know researchers don't want to do a study that's 8 or 10 years long, because it takes that long to be able to announce your results. So can you take the data that you've already gathered and continue with that same patient group or cohort to extend the study to see, as you give continuous therapy, the results past, maybe a 3 or 5 year period? Is that possible? Or do you?
Yes. I think that's another excellent consideration, because we have to, you have to balance the time and the need of have an answer not in 10 years, because it will be too long, with the need of evidence. Today, I think this is the work that we should do all together, patient, physician, and probably also authorities, try to shorten the period to get a signal. From this point of view, I'm very much in favor to find early signal that can allow us to say we do have an evidence that this is effective, and that signal will then be confirmed with longer follow-up. So today we still need the randomized study to clearly show a signal. We should probably start using early signal, such as PFS. PFS may come in less than 3 years. There's a signal. Even response rate, if the difference is very important, can come much less than 2 years after a study. So to have a marker that in 2 to 3 years time period can give us an early signal of evidence. This is, in my opinion, quite important and feasible today. Is less slightly more conservative from this point of view, to immediately translate the experience of a study such as a phase 2 study without a control arm, done on a very small cohort of patients, such as 20, 30 patients, to immediately translate these evidence in clinical practice, because in the past some mistakes have been done with this approach. So in my opinion, we do need phase 3. We do need early biomarker or signal to have an answer in 2 to 3 years.
And in your opinion, what else would shorten up this whole cycle of discovery for you? Is it more patient involvement? Is it structuring the clinical trials in different ways? Or just with your experience, you have so much experience. In your opinion, what would shorten this up so we can discover new thoughts more quickly?
I would say more certainly the ability to open and close those studies in a shorter period of time. I think that's probably is the clue issue, and probably a better collaboration between investigator and authorities to design and to speed up all the bureaucratic procedures, because today, to some extent, if we, in a word, we need standards. If you have a new drug, you should know immediately which is your standard study to do to have the approval, and you should be immediately approve the drug if you reach that endpoint. So you don't have to go through discussion, things should be more standard from a bureaucratic point of view, and from a recruitment point of view. I think those are the two clue issues. If authorities will have standards, they can certainly reduce the time required for approval. If investigators have better facilities, could probably reduce the time required for recruitment. And this might, to some extent, reduce between 30 and 50% the time today required to get approval of a given drug.
Well, that's a huge time frame. We're doubling the pace if we could eliminate that. And do you have a hard time recruiting for your studies? I know that Europe is different than the United States.
but we are in a very good, position because,
right.
Here is no. But generally speaking, another message is that the difficulties in recruitment is mainly due by the fact, this is, if I can, from a European perspective, another very important message for patients. The difficulties in recruitment is because patients are treated in so small, different institutions. And to some extent, this is a major issue, not only for recruitment, but mainly for patients. Patients should remember the number one quality issue is the number of myeloma patients that a given physician see every year. Myeloma is a rare disease. So if patients are treated by physician who sees 2, 3, 4 patients per year, this is quality A. But if a physician sees 150 myeloma patients per year, this is quality B, and this is completely different from A. So one issue is that, especially for rare disease, I know sometimes it's not so easy for geographical reasons, but the treatment should be driven by physicians who see at least 100 patients, new patient per year, because experience makes the quality on top of everything. And of course, if you start having center who see more than 100 newly diagnosed patients per year, also the recruitment will be increased because you will have more concentration.
Right, and to me as a patient, that what you just said is just a no-brainer. My first oncologist that I saw, I asked him how many patients he had. He said maybe 5. And then I went to 2 other specialists, and at their facilities they were treating between 400 and 600 myeloma patients a year. And it was very clear the expertise difference in those. Even though he was a good oncologist, he did not specialize in myeloma, and to me it wasn't worth it. So I completely agree.
I think this is the number one message to give to patients. Always remember, in every type of disease, what makes the difference is the number and of patients that a given physician is seeing, and therefore the experience they might have. So even for surgery, for everything, the number one issue is the number of procedures or new patients you might see per year. That will make a great difference.
Well, yeah, it's a great message. So I have so many other questions to ask you, but I know you need to end at our stop time, and there are several callers. So if you have a question, I'm going to open it up for caller questions. If you have a question for Dr. Palumbo, you can call 347-637-2631. Press 1 on your keypad, and we will start with our first caller question. Please go ahead.
Hi. Am I the caller?
Yep, you're live.
Hi. I didn't know if I was one or not. Hi, Jenny. Thanks for doing this wonderful interview, and thank you, Dr. Palumbo, for being a part of this interview. This is Susie Rose, and my question, we are talking about continuous treatment, and we're looking at the immune modulator drug for continuous therapy. Do you have a perspective? I know this was not your trial, but do you have a perspective on using the proteasome inhibitors and, putting that in the framework of what we were talking about with Jenny and when you refractory in terms of will patients become refractory if they're continued on proteasome inhibitor? And I'm thinking of that for patients who are in the high risk are cytogenetic. They have the translocations or deletion 17p or amplification of 1q. So I'm really asking your perspective more so than, because I know it wasn't part of your trial. So what are your thoughts there?
That's a very complicated question. I'll try to give my best answer. We ran two different studies. One study was LAN maintenance versus no maintenance. The other studies was another independent studies and was proteasome inhibitors maintenance versus no maintenance. If you look at those two independent studies, no question the advantage was fairly similar in both studies. It was around 1 year. Good prognosis patients did better than high-risk patients in both studies. So the issue of high risk was high risk patients did worse both with LAN than with proteasome inhibitors. Having said that, I'm in favor, without evidence, this is a personal opinion, certainly probably to use proteasome inhibitors in high risk, because has been shown that proteasome inhibitors might be more beneficial than IMiD in high-risk patients, and using this evidence together with the evidence that in those two together with the no evidence, because we do not have any evidence to show head-to-head comparison of IMiD with proteasome inhibitor, I will be probably in favor of using a proteasome inhibitors in high-risk patients. In terms of resistance, I actually do not know. I would not expect a high risk of resistance from one drug in comparison to the other, but honestly speaking, I do not know.
Yeah, I asked that question because of the data that Dr. Lonio has now out of Winship, where I think it was more of a retrospective analysis where he looked at keeping patients on RVD after they were in the high-risk population, and he's seen a substantial increase following those patients in their survival. So that was kind of what prompted my question. I realize there's not a lot of evidence, but I appreciate your expertise and giving your clinical perspective. So thank you.
No, thank you very much. Actually, very nice. Thank you. I completely agree with your comment because, from generally speaking, more the disease is aggressive, a more intense treatment such as VRD will be, of course, more beneficial, provided it's tolerated. So I would completely agree with you and Dr. Lonio, provided the treatment you are given is tolerated, because otherwise you have to reduce the dose intensity.
Yeah, that was the other concern that I had in terms of when we're doing continuous treatment like that, are we going to do it at the same pace and the same, are we going to, when you're doing like induction or when you're doing consolidation, typically it's twice a week, 3 times for 3 weeks in a row. Well, would we continue that, or will we do once a week, or would we, you do maybe 1 year you get it twice a week, and then the following year you go to once a week times 3 weeks? I don't know, and that's, one of the questions, because I think your core point is we have to sustain the MRD if we've reached it, or continue to drive it down as much, with the steady pressure of the drug. So I don't know. Do you have thoughts on that? Should the dose intensity? I know with lenalidomide, they take you from 25 milligrams down to 10 or 5 milligrams for maintenance. Would you think we would do it with a because that's the other thing, even carfilzomib is up to 56 milligrams now. Do we back it back down for maintenance? What would your clinical perspective be?
No, my perspective is first, the more is better if it's tolerated. So every time more is not tolerated, there is an excellent reason to go less. So this is rule number one.
So dose-limiting toxicity would be your parameter.
Example, you see, for us, we do re-challenge in continuous treatment if we have at least 1,000 or 1,500 neutrophil and at least 75,000-80,000 platelets. So if you start not having those parameters for us, this is a good reason to stop, wait to reach those levels and restart at a lower dose, because of course if you had to stop it's because the previous dose was not very well taken. So this is rule number one. As a rule number two, I would use certainly no more than a weekly bortezomib, especially in a continuous approach. And our trial did honestly use bortezomib every 2 weeks. So our proteasome inhibitor was much lower when we gave it as a continuous treatment. Carfilzomib could be given more frequently because it has less hematologic toxicity and less neuropathy, but still, rule number one is if tolerated.
Right. Well, thank you.
Thank you very much. Thank you.
Okay, thank you for your question. Okay, we'll go to caller at 305-7339. Go ahead with your question.
Yes, hi. My name is Victor, and I've noticed that clinical trials basically seem to be for relapsed refractory patients, and I'm wondering whether it's possible to design any trials to try some of the newer drugs that are not approved yet, like some of the monoclonal antibodies, for example, for people who are on maintenance. Has thought been given to that, or would that basically just not work because you wouldn't really be able to tell anything?
No, actually, what is ongoing is probably not so, in the public domain. But what is ongoing now are plenty, all new drugs, including monoclonal antibodies, are testing the maintenance phase. So basically, you are right. In the developing of a drug, first you test the drug in relapse refractory, and then you move to newly diagnosed patient. And at that point, you, at the same time with a different study, you address the question of maintenance. So the majority of maintenance questions are in newly diagnosed patient and in treatment administered to those patients.
Okay, but I guess my concern is that for someone who is on maintenance now, there don't seem to be any clinical trials available. You can't just sign up for one if you're already in a maintenance position.
If you are already in a maintenance, no, in the sense that a clinical trial can be, delivered if at the beginning of the maintenance. If you already start the maintenance, there is no clinical trial that will allow the inclusion of a person who already started maintenance, because of course it would be difficult to evaluate the efficacy at this point. Mm-hmm. But on the other hand, I would also suggest you, if you are under a given maintenance, keep going. Don't mix up. The moment you see, when you start the treatment, the moment you make a decision, it's over. Don't change in the middle of the way.
Yeah, no, I'm not going to.
Okay, great. Well, thank you for your question, Victor. Appreciate it. Okay, we have another question at 985-1296. Go ahead with your question.
Hello, am I live?
Yep, you're live.
I did have a question with the maintenance of Revlimid. Does doctor suggest that dexamethasone is also a component in that regimen?
You're asking me if we should add dexamethasone, yes or no. There is some evidence, they're not very strong, honestly, because that the addition of corticosteroids might be useful. So you might add it. The studies we have been running until now have been only study comparing IMiDs or proteasome inhibitor without dexamethasone versus control arm. So the study we do have, and the real strong evidence is without corticosteroids. There are some studies that they are adding corticosteroids to Revlimid. They do not have enough follow-up to make a final conclusion. Early signal might say that there is an advantage, so that's why I'm not so strong in saying yes or no, because I'm strong in saying yes for LEN maintenance, because we do have a strong evidence. For the addition of corticosteroids to LEN, we have some initial evidence. So my answer to you will be yes, provided corticosteroids is not creating any trouble to you, and probably even lower doses, 10 to 20 milligrams of dexamethasone might be good enough. So yes, provided is not creating any trouble to you, knowing we have some early evidence, not strong evidence.
Thank you very much, doctor.
Thank you.
Okay, we have our last caller at 949-5572. Go ahead with your question.
Hey, thank you very much for taking the call. It's been a great show today.
Thank you.
Dr. Palumbo, you make a very compelling argument for a continuous therapy approach. A couple of questions around that. What is a quality of life issue that would stop you from continuing the treatment? You mentioned that the quality of life would be a significant factor. How bad would the neuropathy have to be, or what would be that quality of life issue? You mentioned kidneys. What else would be those issues? I have a couple other questions after that.
Well, I'm not going in detail because for me, as I usually say, only grade 1 toxicity. All toxicity has been graded. They are graded by 1, 2, 3, 4. So we usually accept grade 1 toxicities, including fatigue. We do not accept more than that. So if you ask me, the cutoff is grade 1. That means minimal toxicities. And on the quality of your life, you will decide at the end of the story, because you might find, some minimal side effect very important, and for me might not be the same. So especially for quality of life, you have to decide. My message to you is you must have a normal life. Every time you feel something is not acceptable for you, I will discuss in detail what this means, but the final decision is on you.
Thank you. The second question has to do with just the cost of continuous therapy. You mentioned sometimes insurance companies won't cover the ideal treatment. Are the insurance companies going to go along with the concept of continuous therapy, or do you have any indication of this? Yeah.
This is something that is outside I think, I'm here in Europe, so it's a completely different situation. I think the majority of companies covering the continuous therapy in United States. In Europe is still under discussion. The reimbursement should become soon. What can I tell you? I don't know. Should be covered, in my opinion, but depending on the insurance, someone might not.
Okay. Last week, the previous show was talking about the new heavy light test, and that test is kind of like a speedometer for the growth rate of myeloma. And I believe it was Dr. Stephen Harding of the Binding Site that did that. Are you familiar with this test? And could some of these tests be used in combination with this continuous therapy as a more sensitive indicator of how the myeloma is or is not progressing? And maybe the concept of a patient dashboard is kind of a radical idea. But as I've been listening to the shows, it's some of these ideas are coming together in terms of how we can help improve the quality of care. And the idea of monitoring at a more sensitive level is a very exciting one to me.
Yes, I completely agree with you. We are testing several new approaches that are more sensitive. But from a practical point of view, we do not have any evidence on how to use it, for example, to stop the continuous treatment and eventually to restart, or when to increase it, the dose intensity of the continuous treatment. So generally speaking, these are not tests that we can use today to make treatment changes. So from this point of view, I think they are still under investigation. They are more sensitive, but they are still under investigation.
All right. Well, thanks again. Great insights today. I learned a lot.
Well, thank you.
Okay, Dr. Palumbo, we are out of time, and we could talk for another hour on your research. You've done so much with...
If you have another couple of questions, fine to me. It's not a problem.
Well, I limited the time on the caller questions so we could end on time.
Okay,
so I apologize. I have quite a few questions about your treatment in the elderly and risk stratification, so maybe I'll end with one. During the International Myeloma Working Group that was videotaped by the IMF, you mentioned that it was needed to separate patients into more homogeneous groups in order to risk stratify them and treat them differently. Mm-hmm. Are there any other steps that need to be taken to treat patients more specifically?
Well, no. You see, I think there is a message, but I think will come. Basically, myeloma is at the end of the day a mix of 3 different diseases. The real high risk, that is a disease completely different from the standard risk and low risk patients. So I think there are today the tools to differentiate those 3 different groups that to some extent may represent the 3 different diseases. And what is needed in the future, but might become more complicated for the need of numbers, because numbers becomes, of course, smaller at that point, to have studies evaluating the high-risk patient, standard risk patient, and low-risk patients separately. Today we have been made the mistake, if I can, but to pull everyone together, and they starting to say this must be better than the other, maybe comparing high risk versus standard risk. Tomorrow, I think the future will be to start a design trial only for the high risk and trial only for the standard risk.
Oh, well, I completely support that. Then you're comparing apples to apples and not apples to oranges. And then you don't know what,
yes.
Don't know what kind of result you're getting.
So I think in the future we are going there, but once again, it's a rare disease, so the issue is mainly related to the rarity of the disease.
Okay. Well, if you have time, I'll add one more emailed-in question from Jill, and she just asked, I noticed that in your studies you are moving away from melphalan to cyclophosphamide. Is there a reason for this, like a less risk of secondary cancers? Can you describe the rationale?
Certainly, yes. I would say that the number one issue of melphalan is the risk of second cancer. So cyclophosphamide has a much lower risk of second cancer. So number one reason to move from melphalan to cyclophosphamide is the lower risk of cancer. The second reason is there is less hematologic toxicity with cyclophosphamide, and this is another important consideration because at the end of the day, if you use melphalan extensively and the platelet count is going down significantly, then there are difficulties in the liver salvage treatment. And this is probably more even important of second cancer. Second cancer is fortunately a rare event. The risk of thrombocytopenia after significant delivery of especially oral melphalan, much less high-dose melphalan because it's a shot given once. With the oral melphalan, but also, if you want, with the high-dose melphalan, the risk of thrombocytopenia may hamper the delivery of effective salvage treatment. And this is, in my opinion, a good reason to move to a better tolerated compound such as cyclophosphamide.
Oh, that's very, very interesting. Is cyclophosphamide powerful enough to use it pre-transplant?
Absolutely, yes. To some extent, in the combination with bortezomib, today we have two major combinations, I would say. Bortezomib plus lenalidomide and bortezomib plus cyclophosphamide. Of course, the first one is slightly more active, certainly more expensive, and the second one is slightly more active than the combination bortezomib and dexamethasone.
Okay, well, that's very, very interesting. And I think we'll see more on that later. Well, Dr. Palumbo, thank you so much for joining us today. We are so very grateful for your leadership in myeloma and your research to move the field forward as quickly as possible.
Well, thank you very much for the invitation. I appreciate it. Thank you very much.
Oh, you've been delightful. Thank you so much. Well, thank you for listening to another episode of Innovation in Myeloma. Join us for our next inpatient radio interview as we learn more about how we as patients can help drive to a cure for myeloma by joining clinical trials.
Lucky Land Casino, asking people, what's the weirdest place you've gotten lucky?
Lucky? In line at the deli, I guess?
Aha, in my dentist's office. More than once, actually.
Do I have to say?
Yes, you do.
In the car before my kids' PTA meeting.
Really?
Yes.
Excuse me, what's the weirdest place you've gotten lucky?
I never win and tell.
Well, there you have it. You can get lucky anywhere, playing at LuckyLandSlots.com. Play for free right now. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+. Terms and conditions apply. See website for details.